Spinal cord lesions produce predictable patterns of motor, sensory, and autonomic dysfunction depending on the level, extent, and location of the injury. When you encounter a patient or case, first determine whether the lesion is complete or incomplete, then localize it by mapping motor weakness, sensory loss, reflex changes, and sphincter function. Let's explore the major syndromes. Complete transverse lesion. A lesion that completely severs the cord at a given level abolishes all function below that level. Voluntary motor control is lost. Upper motor neuron signs below the lesion with initial spinal shock, flaccidity, areflexia, then hyperreflexia, spasticity, sensory modalities are gone, pain, temperature, touch, proprioception, and autonomic control, bladder, bowel, sexual function, blood pressure regulation, is disrupted. The segment at the level of injury shows lower motor neuron signs, flaccid paralysis, muscle wasting, absent reflexes, because the anterior horn cells are damaged. Clinically, you'll see a sensory level, a sharp line between preserved sensation above and absent sensation below. Brown-Séquard Syndrome, hemisection. When one half of the cord is damaged, the pattern of deficits reflects the crossing of pathways. On the site of the lesion you find ipsilateral upper motor neuron weakness and loss of proprioception and vibration, dorsal column, while pain and temperature are lost contralaterally starting 1 or 2 levels below. Spinothalamic tracts cross near the anterior commissure. Reflexes are increased on the ipsilateral side below the lesion, and there may be a flaccid segmental paresis at the level of injury. Sphincter involvement varies. Anterior cord syndrome. Injury to the anterior 2/3 of the cord, often from anterior spinal artery infarction or flexion compression injury, spares the dorsal columns. Motor function is lost bilaterally below the lesion, corticospinal tracts, and pain/temperature is lost bilaterally, anterolateral tracts, while light touch and proprioception remain intact. Autonomic dysfunction is common. Central cord syndrome. Typically due to hyperextension injuries in older patients with cervical spondylosis, the central gray matter and crossing spinothalamic fibers are damaged more than lateral white matter. Pain and temperature sensation are lost cape-like in upper extremities, motor weakness is greater in the arms than the legs, and bladder function may be transiently impaired. Proprioception is preserved. Posterior cord syndrome. Rare, from involvement of the dorsal column's tumor, infarction, or compression producing loss of proprioception and vibration below the lesion. Patients have sensory ataxia, positive Romberg sign, and wide-based gait, but motor strength and pain/temperature sensation remain largely intact. Conus medullaris and cauda equina syndromes. Lesions at the terminal end, conus medullaris, spinal cord termination around L1-L2, cause early sphincter dysfunction, symmetric lower limb weakness, and mixed UMN/LMN findings. Cauda equina lesions, below L2, involve the nerve roots, produce asymmetric radicular pain, flaccid paralysis, absent reflexes in affected myotomes, saddle anesthesia, and early bladder/bowel areflexia. Cauda equina syndrome is a surgical emergency. Other patterns. Posterolateral column lesions, e.g. subacute combined degeneration from B1-2 deficiency, damaged dorsal columns and corticospinal tracts produce loss of vibration/proprioception and spastic paresis, with sensory ataxia. Syringomyelia. A fluid-filled cavity in the central canal expands and compresses, crossing spinothalamic fibers, bilateral cape, loss of pain/temperature in upper limbs while sparing dorsal columns and corticospinal tracts until late. Key steps in evaluation. 1. Establish the neurologic level by testing dermatomal sensation and myotomal strength. 2. Distinguish UMN versus LMN signs. 3. Map the sensory modalities to recognize tract involvement. 4. Assess autonomic function bladder, bowel, sexual. 5. Consider imaging, MRI, to define lesion location and nature trauma, infarct, tumor, demyelination, infection, or metabolic causes. Understanding these syndromes lets you localize lesions accurately, anticipate complications, and plan urgent management. Spinal cord pathology is dramatic, but precise localization guides effective treatment and improves outcomes.